Hello everyone, I am Dr. Anuja Reddy, founder of Dr. Anuja's Physiotherapy Clinic, Kharadi, Pune. I have 7 years of experience in physiotherapy. Today, I am going to show a case study of total hip replacement. The hip is a ball and socket joint. This type of joint allows a good range of movement in any direction. The ball of the hip joint is known as the femoral head and is located at the top of thigh bone, the femur. This rotates within a hollow socket in the pelvis called the acetabulum. Hip replacement surgery involves removing parts of the hip joint that are causing problems, usually the ball and socket, and replacing them with new parts made from metal, plastic, or ceramic. Thousands of people have hip replacement surgery each year. It usually brings great benefits in terms of reduced pain, improved mobility, and a better quality of life. The most common indication of total hip replacement, hip or osteoarthritis. Other indications include trauma, can be considered in a case-by-case basis in femoral neck fractures in active and healthy patients. Osteonecrosis of the hip, commonly known as avascular necrosis of the hip. Developmental dysplasia of the hip. Hardware failure after internal fixation of hip fractures. THA is contraindicated in the following clinical scenarios: local septic infectious arthritis, remote extraarticular active ongoing infection or bacteremia, severe cases of peripheral vascular disease. A 35-year-old female, a teacher by occupation, came with the complaint of pain on the left side of the hip region for the past 15 days, along with difficulty walking. The patient was apparently alright 1 month ago when she tested positive for COVID-19. While she was quarantined, she started experiencing pain on the left side of the hip region, which was gradual in onset and progressive in nature, aggravated by walking, squatting, and prolonged standing, and relieved by rest. After her recovery from COVID-19, she visited the rural hospital, where an X-ray was done, which revealed avascular necrosis of the left femoral head. The patient was advised to have a total hip replacement and underwent the surgery. After 1 month, the patient started experiencing pain on the right side of the hip region. She visited the rural hospital where an X-ray was carried out, which revealed destruction of the femoral head. She was diagnosed with avascular necrosis of the right femoral head. Physiotherapy rehabilitation was further started. Prior to the assessment, informed consent was taken and the patient was positioned in the supine lying position. On general examination, the patient was conscious, cooperative, well oriented to time, place, and person, hemodynamically stable, and afebrile. On observation, the patient was having the antalgic type of gait with both hips externally rotated. The limb length on the left side, that is on operated side, was shorter than on the right side. On inspection, the surgical scar was present on the left side. On palpation, the local temperature was not increased. Grade 2 tenderness was present on the left side and grade 3 tenderness was present on the right side. The hip range of motion was observably reduced and all hip movements were painful. The hamstrings and abductor muscles were tight on both sides. Postoperative complications may occur during the early period of recovery, before 6 weeks or up to 2 to 3 months, which include wound healing problems, dislocation of the prosthetic joint, disruption of a bone graft site before sufficient bone healing has occurred, and leg length discrepancy. Late complications include mechanical loosening of prosthetic implants, problem of polyethylene wear. Post-operative management includes immobilization. After THA, there is no need for immobilization of the operated hip. Post-operative rehabilitation emphasizes early movement, depending on the type of surgical approach used and the stability of the prosthetic hip. The operated limb may need to remain in a position of slight abduction and neutral rotation when the patient is lying in bed in the supine position. Abduction pillow or wedge typically is sufficient to maintain the position. The weight bearing considerations: after cemented THA, typically patients are permitted to bear as much weight as tolerated almost immediately after surgery. With cementless or hybrid THA, it is often necessary to limit weight bearing on the operated limb for the first few weeks or up to 3 months. The maximum protection phase: prevent vascular and pulmonary complications. Ankle pumping exercises, deep breathing exercises prevent post-operative dislocation or subluxation of the operated hip. Patient and caregiver education about motion restrictions, safe bed mobility, transfers and other precautions during other ADL. Monitor the patient for the signs of dislocation, subluxation such as shortening. Achieve independent functional mobility prior to discharge. Bed mobility and transfer training. Integrating weight bearing and motion restrictions. Ambulation with an assistive device, usually a walker or 2 crutches, immediately after surgery. Adhering to weight bearing restrictions and gait related ADL precautions. Maintain a functional level of strength and muscular endurance in the upper extremities and unoperated lower extremity. Active resistive exercises in functional movement patterns, targeting muscle groups used during transfers and ambulation with assistive devices. Prevent reflex inhibition and atrophy of musculature in the operated limb. Muscle setting exercises of the quadriceps, hip extensor and hip abductor muscles, just enough to elicit a muscle contraction. Regain active mobility and control of the operated extremity. While in bed, active assistive exercises of the hip within protected ranges, knee flexion and extension, ROM exercises emphasizing terminal extension, progressing to active hip and knee flexion, that is heel slides. Gravity eliminated hip abduction if permissible by sliding the leg on a low friction surface. All the above exercises must be done in supine. Active hip exercises in the standing position with the knee flexed and extended with hands on a stable surface to maintain balance. Closed chain, hip flexion and extension, placing only the allowable amount of weight on the operated extremity. Prevent a flexion contracture of the operated hip. Avoid use of a pillow under the knee of the operated extremity. After traditional THA, the intermediate and late phases of rehabilitation begin about 4 to 6 weeks post-operatively. Regain strength and muscular endurance. Open chain exercises within the permissible ranges in the operated leg against light resistance, more number of repetitions rather than resistance to improve endurance. Bilateral closed chain exercises such as mini squats against light grade elastic resistance. Unilateral closed chain exercises such as forward and lateral step ups to a low step and a partial lunges with the involved foot forward when full weight bearing is permitted on the operated lower extremity. Improve cardiopulmonary endurance. Non-impacting aerobic exercises such as swimming, stationary cycling. Improve postural stability, balance and gait. Emphasize use of a cane in the hand contralateral to the operated hip and progressive weight bearing on the operated limb. While using a cane, walk over uneven and soft surfaces to challenge the balance system. While using a cane, walk over uneven and soft surfaces to challenge the balance system and gait training.